Mr. Chairman and members, thank you very much for gathering here and giving us the opportunity to come and give you a brief presentation on local pharmacies in Louisiana. My name is Randal Johnson. I work for the Louisiana Independent Pharmacies Association, and I think that you have a little packet of information in front of you that I just wanted to share to make certain that you have an opportunity to look at some of the things we're talking about. We'll leave that information with you, but I wanted to thank you for the attention that you've always given the pharmacies they have. The pharmacies themselves find themselves as the most accessible healthcare provider. They find themselves in somewhat that appears to be a retail setting where a patient is able to walk in and speak to that pharmacist with no appointment necessary. About half of our pharmacies in the state that are retail pharmacies or small business independents, about half are chain drug stores, including those who are in grocery stores and big box locations. We've had the opportunity to put together a map for you to just give you an idea about that as we look. And I think that if you look at that map, then we've got one that shows you a lot of blue dots that are pretty predominant. You don't have the handout? Sorry about that.
Thank you.
So our state is, as we look at healthcare providers there, that we find that pharmacists are very prominent in that. We wanted to talk today a little bit about the Medicaid program, and I know there's some folks from the Medicaid program that are in here offering themselves if they would like to have any questions. You'd like to have any questions. But our Medicaid program is something that serves nearly 2 million people in our state. In that Medicaid program, that there's about 20 million prescriptions that are filled each year. In fact, the pharmacists find themselves processing about 27 million prescriptions for the Medicaid population, but they have the opportunity to work through different issues and concerns that appropriately dispense about 20 million prescriptions a year for the Medicaid population. That program costs right at $2 billion gross and draws in about $1 billion in rebates. That information's in there for you. It's supplied by the department. We've worked with the department for a number of years, and including back in 2010 and 11, we were able to work with the Department of Health and offer some cost savings there. The department made some changes there in 2019 related to pharmacy reimbursement, and the way our pharmacy program is done is it's a cost-based reimbursement. It's two pieces, both the ingredient cost and the dispensing fee. We think that's a very successful way to look at that. And in fact, we had a good meeting at the department last week with a council that you created to talk about Medicaid pharmacy reimbursement. They have the experts that they've contracted to bring in, and we spent a day talking about the way they produce those costs for both the dispensing fee and the ingredient cost. We may continue to talk about that. That'll be a report, I believe, that'll be coming to the legislature as you convene next year. But the opportunities that we look at with our pharmacy program are significant. You've got 5 MCOs, soon to be 6 MCOs, and then also the fee-for-service program. And we do look at coming with January 1. Medicaid has gone through a Medicaid pharmacy re-enrollment and a pharmacist re-enrollment. So we look at the opportunities to continue to serve that population out there. One thing that is interesting is we look at the way that we have had transparency in the Medicaid pharmacy program has given us the opportunity to look that $2 billion in expenditures brings in about $1 billion in rebate, just rounding that up. Comparing that to the Office of Group Benefits, what we have there is that's providing the care for about 200,000 people, or about 10% of the Medicaid population. And in that program, they're planning to spend about $500 million a year. That includes that the state employees, their dependents, and retirees have a copay that exists in that program. where the Medicaid program has a limited copay, and while that copay has been set aside through the public health emergency, then we are looking, and I think I provided you with some information there on the page that says pharmacy benefits comparison, just to make certain you're all so focused and so knowledgeable on the different things that are happening. But if we compared the successes of our Medicaid program, then we will see that the gross cost of the Medicaid program is running out pre-rebates at about $1,179 per member per year for prescription. If we do that net of rebates, then that's $581 per member per year for prescription drug services. If we compare that to the group benefits program, then we're seeing that's costing a little over $2,000 per member per year for prescription drug services. I mention that because as you talk about your variety of roles where it comes to Medicaid, which substantially is a payment process that we have, we also look at the cost that you have to deal with as state employees, as state officials, as dependents or retirees of state government, and look at the increasing cost of health care. So our Medicaid program has in some manner been substantially successful in reining in the cost of prescription drug services. And we think that the lessons that Medicaid may have been able to look at and work together with the providers in order to put in place are some lessons that our state broadly could look at when it comes to the Office of Group Benefits, and some savings available there.
Representative Edmonds for a question.
So in looking at the sheet one that's on our presentation that you're giving us, so Medicaid found some kind of way to keep this at $581.46. That's in the middle of the page. And you're saying that the significant difference between that and what they have learned in comparison would be over $2,000 for the OGB that we're now under contract that's in debate right now.
Yes, sir.
And you think those numbers are accurate?
Well, the numbers that are for the Medicaid program come from the Medicaid program and come from the documents that they've produced. And the numbers from OGB come from the presentation that OGB made to the Joint Legislative Committee on the Budget.
It's odd that in a lot of other Medicaid services, we don't see a variance in our favor like this one. This is an odd number that OGB would be that high on this contract in comparison to. Is there any idea of how Medicaid services have been successful to keep the number at that kind of level?
I think that what we've had is substantially there are some rebates that are out there for the manufacturers, but most particularly the Medicaid program historically has worked with the providers in order to be able to design a program, because these pharmacists that are out there, they're taxpayers also. They're sitting there in their store keeping their doors open. And so Medicaid has gone to a cost reimbursement methodology, and we're looking for what the cost of the drugs are. We're evaluating what the cost of that pharmacy providing the service is. And we suggest that the transparency that the Medicaid program has seen would benefit the state having that transparency in other matters also.
Yep. So you're talking about our independent pharmacies.
Yes, sir.
Across the board, across the whole state, right?
Yes, sir.
And they've worked out these rates and reimbursements to try to get it and keep it to that level.
Yes, sir. And this impacts all pharmacies.
Yeah.
It's not just independents. The independents get a little bit more focused because the big chains may have a national contract that they work across the nation on. The independents are looking at what happens in our own state and focused working with Medicaid on that. So what we've done has, while it's something that the independents have embraced, it's something that the chain drugstores have supported also.
Yeah, and so for the figures that you're giving, the Medicaid program is a lot larger than OGB. It would seem it just seems reasonable that, and again, I'm not asking you to ask outside of your reference that you've had, but to your experience, has the administration looked with independents and others to try to model a similar program to make this work?
I don't think we've gotten to that point yet. I believe we're still looking at a model and a design that may be decades old. There are some new opportunities that the state has looked at. In fact, you in the legislature passed 2 years ago, I believe, what they talk about is the caption was a reverse auction. And I believe that what you looked at there was bringing transparency to this prescription drug process. There are a number of states that had done it, Maryland, New Jersey, and a bipartisan activity with both Chris Christie as governor, as a Republican, and a Democratic leader of the Senate. We saw some things that are going on in a number of different states in West Virginia that moved their state employees program into patterning the Medicaid program for that. And it offers substantial savings by getting that transparency. With what you passed in the legislature with the reverse auction, gives you an opportunity to establish the guidelines on what you're looking for and vet the companies that want to bid on that, and then open up on a particular day and design that those companies can bid, and who can do that, what qualified bidders can do that for the state and its employees at the lowest possible cost.
Do you have a sort of sheet of explanation of some of these things that we could have for joint budget on Friday? Because I'm sure we're coming right back to this discussion, and obviously it's very interesting at 500 to 2,000. This is something very interesting to us. We could receive great service at that much less money. I mean, do you have, and I hate to say bullet points, but I mean, what do you have that you could provide for us for joint budget?
Well, I think that this information right here could be of benefit to you, sir. I mean, I think we put this in a design that whether we're talking about Medicaid or whether we're talking about the state employees, we're talking about people's health. I don't think that our Medicaid population is so substantially different than the rest of the people in the state. It just goes to an income level. You know, it could be something that because of the income level or because of the healthcare conditions, any of us could be impacted by.
If you have any other description of how Medicaid has done this that you could provide for me, I would like to have it so that we could have. I use this as well.
Yes, sir.
For Friday's meeting, because we're in a serious move of trying to look at a contract, as you well know now, and this seems like some great information that might help our state.
Yes, sir. Well, thank you very much. We will work to put
Thank you.
the information together for you.
Thank you.
Bacala?
Yeah, thank you. Just trying, and again, I think that there's some validity to the fact. I mean, 500 to 2,000, the 3.5 times. I do want to just mention this, that the populations are not the same for a couple of reasons. Number one, I think if you look, I think in the industry they call it the census, and the younger you are, the cheaper you are. Right? I mean, kids don't have renal failure and the things that are very expensive. So that's one aspect that creates some disparity between the two. I think the other thing that creates some disparity is the oldest of the population is what costs the most in pharmacy. And within the Medicaid population, most of the elderly are dual enrolled, so that actually they're enrolled in Medicaid, but Medicare takes care of their prescription drug costs. So there is something of a disparity when you try to look across both. And I'm for your point, but I'm also want to be clear that it's a little bit more difficult just to count heads. You have to have a complete census, I think, to make an accurate crossover between the two. But at the same time, I'm looking for a better way than what we've had before in OGB. And I know that one of the big issues is, the independents not being reimbursed even at their cost. And the nationwide, I think some of the most profitable companies in the world are PBMs, and we ultimately pay it. And I really don't get the whole rebate thing. We're going to pay you too much so you can give us some back. Anyway, I just wanted to call attention to the fact that there is some differences between the Medicaid population and the OGB population. I don't even know if they count PBM per member membership the same. I know different places. In some places, a member is one person and their family. So there may be a head count difference. I don't know that exists either, but I know that there's a per member per month may be a member plus dependents, or it may be everybody. And I know different people do that differently, and I know this from my prior world. So anyway, I think we need to dig into it more. I know that you've seen probably everybody in this room who sits on that joint budget turn away this latest contract more than once because we think we're getting screwed, quite frankly. But anyway, and the local pharmacies are even getting worse. So anyway, that's it.
Well, Representative Bakala, just to mention a couple of quick points. One, if we look at those numbers, members with pharmacy benefits in that line there, then what we have is there's about 2 million members, just under 2 million members of the Medicaid program. There's 1.6 members that received pharmacy benefits. So you end up with 300,000 that didn't receive a pharmacy benefit. Okay. Likewise, when you look at OGB, there's a little over 225,000 members of OGB. There's 198,000 of those that received a pharmacy benefit. So we did look at that. And while there is a lot of children, a great number of children in the Medicaid population, there are also folks that are very, very ill in the Medicaid population and have very high cost of care. I was a state employee for a generation, and as I got older, I did not retire from the state because I left before I retired. But there seems to be somewhat a rule of thumb that as you get older, you take a prescription drug for every decade of your life. So I'm about even on that right now, and I will tell you that because I have Blue Cross Blue Shield and I have an HSA, a private policy where I have to pay my cost of drugs, my prescriptions, and I'm currently, because of the injury to my back, I'm taking 5 prescriptions. That is what I regularly get filled, and it's under $20 per month for me to get all 5 of those prescriptions filled. Using the PBM, if I were a state employee, there would be an average of $85 per prescription that that the state would be paying for each of those prescriptions. So there's a lot of difference there that when we look at these costs, using these contracts that we've seen, my Lipitor, my generic Lipitor, which is $4 for a 90-day fill, the state would be paying, if I were a state employee, more than $112 for that same 90-day fill. So the transparency, I know that you folks are all experienced in looking at what things cost and looking at where costs are hitting. The transparency that we have with prescription drug pricing is important for you to be able to see.
And listen, I think probably what we need to do, if we're going to compare the two plans, we need a complete census breakdown so we can get a better idea of whether they are equal or not. Can we count person per person? But I can't imagine why there isn't the opportunity to actually compare that census data between Medicaid and Medicare to add validity to the numbers that you're giving us.
I think that we've attempted to get that to work with them at the Office of Group Benefits.
Who?
I think the opportunity is probably for you to ask your legislative auditor to be able to work on this for you.
Well, you said ask them. Who's them?
At the Office of Group Benefits. We've asked for information, and they've substantially told us that their consultant, Buck, does this for them, and they don't need anyone else involved. And just one thing I will mention, as we've seen, we believe that what is occurring is market standards. Well, if we have 3 large PBMs that are together more than 85% of the marketplace, then that sets the market standard. That doesn't mean it's right. And our pharmacies aren't against PBMs. They are a necessary part that we are working with. We understand it. In fact, in the Medicaid program alone, we already work with 5 different PBMs. So it's not something that the pharmacists aren't familiar with.
Well, the census data is going to be used for the bid. So I can't imagine that it didn't. I don't know if it's a public record or a non-public record, but obviously no company in the world is going to bid a ceiling if you don't understand who the population is, what their prescription drug history is, all that stuff. So it's got to be there. And I don't know. Okay, I know we're getting away from Medicaid, so I'll stop it there.
Thank you so much.
All right, the board is clear. Thank you. All right, members, I'm going to meet with you afterwards. Members, the board is clear.